Thank you so much, Doctor, for the nice introduction. And my thanks also goes to the organizing scientific committee of the conference. I have no disclosure. This is a simple agenda of what I'm going to talk about today. You have a simple introduction, simple pathophysiology talk, treatment overview, and we're going to talk about prior trials, talking about therapy, emerging therapy of pruritis, specifically in PBC. And lately, I'm going to talk about what's new in the ACLD 2025 updates. So as we know, PBC is a chronic autoimmune cholestatic liver disease, and the pruritis is one of the most common and maybe the first presenting symptoms. It affects around 20 to 70% of patients with PBC. It may precede diagnosis by many years, and because of poor correlation between severity and there is also poor correlation between severity and biochemical markers. So it's not unusual for a patient to present with only pruritis with completely normal liver enzymes. So pruritis affects quality of life in many aspects. A lot of these people with pruritis can present with other symptoms in association with the pruritis itself. Pain and discomfort, anxiety and depression, and affection of mobility, affection on the usual activities. And people with PBC and severe pruritis, 54% of them will present with severe sleep interference, and 31% of them will present with severe depression. And if you look at the left, I just want to ask you to look at the last line. People with PBC and severe pruritis and severe depression, they have an overall health utility score much lower and worse quality of life if we compare it to heart failure, COPD, HCC. And we all know that all of these conditions are really severe and affecting the overall health, mortality, morbidity, and quality of life. Oh, sure. So in terms of pathophysiology, we cannot point to a single etiology of pruritis and PBC. We know it's multifactorial. It happens because of altered bile acid metabolism, where there is an increased level of bile acid, reduced excretion. There is alteration in FXR and PPAR receptors activity. There is also a role of neuroactive substances, including the activation of MAO opioid receptors, increased level of LPA acids, and the autotoxin, which also increase the level of this acid. And there is noticed and proven increased interleukin 31 level in these people. Also, we can attribute the pruritis to the presence of dysregulated pruritogenic signaling, in addition to presence of neural and central mechanism in the brain and the spinal cord. So when we talk about treatment, we all know that there is an unmet need in treating pruritis in PBC patients. The first line of treatment, the ursodeoxycholic acids, improve the biochemical parameters, first line of treatment, but it has no consistent effect on pruritis. And it's endorsed by both ACLD and the EASL guidelines that antipruritic therapy should be addressed separately than the treatment for PBC itself. Treatment can be challenging in sometimes, although the origin of the pruritis in PBC has non-histamine etiology, but there is antihistamine minimal benefit, and mostly not because of the effect on the pruritis itself, but because of the sedative effect of the antihistamine. We can start with it, but usually it's not that effective, and patients will come back to you saying that they are not effective. I'm taking large doses, I'm being sedated, but the pruritis is not gone. So, and we follow a traditional stepwise approach. Traditionally, we go with the first line therapy with bile acid sequestrant, cholestyramine, followed by second line therapy, which is the rifampicin, and then third line, including the opioid receptor antagonist like naltrexone, and some emerging therapy, and not much evidence on it, such as SSRI, use of IBAT inhibitors, and then in the refractory pruritis, even transplant can be considered in such cases, or plasmapheresis. So I'm going to talk now and go over some landmark trials published over the last 5-6 years on the treatment of pruritis in PBC. And actually, all of them are landmark trials. So the BIS-ORSO trial, published in 2018 in New England Journal of Medicine, that studied the effect of bezafibrate at a dose of 400 milligram PO daily versus placebo for 24 months in 100%, in 100 patients randomly assigned to these groups. And those people are, of course, PBC with inadequate response to the ORSO. The secondary endpoint of this study was a reduction of the H intensity score, and that was actually measured. There was 70% median reduction in H intensity in the study group versus 0% in the placebo group. It was followed by the FITCH trial, published in 2021, and again it studied the bezafibrate, but not just in PBC, but in fibrosing cholangiopathy, including PBC, PSC, and secondary sclerosing cholangitis. 24 patients of the 74 were PBC patients. It was a short-term study for 21 days, and they compared it to placebo group. The primary endpoint was more than or equal to 50% reduction in the H intensity. That was observed in 45% versus 11% with a very significant p-value. And if we talk about when we do the subgroup analysis, it was 55% versus 13% in the PBC group. Elative trial, and it was the study that was published on introduction of elafibranor as a second-line treatment of PBC. So that the protocol of the study included giving elafibranor 80 milligram PO once daily versus placebo in 2 groups of patients with PBC who had inadequate response or they were intolerant to ORSO. The secondary endpoint, they found that the worst H scale dropped by minus 1.93 points with the drug versus minus 1.15 with the placebo. This is not statistical, it is clinically significant, but not statistically significant. But when they used the different score upon using the 5DH and PBC-40H domain, elafibranor showed significant improvement in sleep, 80% versus 30%, and quality of life. In response trial, published in 2024, which is the study on the seladelpar at a dose of 10 milligram PO once daily for 12 months versus placebo, and also patients with PBC who had inadequate response intolerance to ORSO. The key secondary endpoints was the effect on pruritis. There was very significant itch reduction, and especially in people with moderate to severe itch. There was 25% of them reached an itch score of 0 or 1 versus 0%, which means near resolution of this debilitating symptom. And in patients who had not have an itch, 0 at the beginning of the study, 0% developed a new itch versus 27% in the placebo group. And I think this is impressive too. On the 5DH scale, there was a significant improvement in the 5DH scale. There was significant improvement in sleep quality recorded as early as week 4 and maintained through month 12. Before 2025, IBAT inhibitors, there were multiple trials, but mainly in pediatric and not specifically in PBC, but they were in cholestatic liver disease in pediatric age group, including Alagille syndrome and PFIC. And there are multiple, and we can talk to them in a different occasion. And then we'll move to the new updates. The GLISTEN trial, the result of this trial was presented at the ASLD 2025, and the actual publication was released just last week. So it's about the linerixibat use in patients with primary biliary cholangitis and cholestatic pruritis, which is a randomized multicenter double-blind placebo-controlled trial, phase 3. They recruited patients at 115 centers in 19 countries, and it's multi-ethnic groups of patients were included. So the protocol of this study, they screened patients over a period of 6 to 8 weeks, and then they randomized them into two groups. The study group, 119, they received 40 milligram BID, and the placebo group, same number, 119. They were followed during the primary intervention group over a period of 24 weeks. And by the end of the 24 weeks, there was a blinded crossover period over 8 weeks. Again, both groups were randomized to receive either the medication or the placebo, and then they were followed up. To study the primary, the first period was to study the primary endpoint of change from the baseline monthly itch score over 24 periods using 0 to 10 worst itch NRS score. The baseline characteristic of the study participants were equal. Most of them were female. They were taking in consideration the use of concomitant orthodeoxycholate use or concomitant use of medication that can affect the pruritis, such as obeticholic acid fibrates. And also the groups were matched in terms of the severity of their liver disease. The result of the study, as we can see, it's kind of a busy slide, but it has a lot of important information. As we can see, for the primary endpoint, there was a significant reduction at a period of 24. If we compare it, there was a reduction in the score from in the study group minus 2.86 points in comparison to 2.15 in the placebo group. But the most important, if you can see, that the reduction was pronounced very quickly, very fast effect by week 2 of the study. And this is actually, again, it's impressive. They also looked at the effect of the medication on the quality of the sleep. And as a secondary endpoint, they looked at the amount of the reduction of the itch, and it was more pronounced in people with reporting reduction of more or equal to 3 points at the score. If you know, another finding in the study that confirmed the benefit of the medication is when they did the crossover period, we noticed that there is a reduction at the bile acid level, an increase in the reduction in the level in people who were started in medication, an increase in the level in people who were who stopped the medication or were placed on a placebo. Medication was very safe. The most common side effect was diarrhea. Not only for people had to stop the medicine because of intolerability. So in summary, linerixibat is a first-in-class IBAT inhibitor for alleviating pruritis in patients with PBC, demonstrating an improvement in pruritis compared with placebo at week 2 and over 24 weeks with good safety profile. The primary outcome estimates were comparable in patients receiving the concomitant pruritis medication and those who were not, and also similar in patients receiving concomitant fibrates. And this abstract was also presented at ASLD last meeting, and it's like a subgroup or a study that we're taking some data from the same study that we just discussed. And here they studied the reduction interleukin 31 with linerixibat and they found it associated with pruritus response in patients with PBC and cholestatic pruritis in the phase 3 Glistin trial. So what they did here, they measured the serum interleukin-31 level at baseline and weeks 4, 8, 12, and 16, 20 and 24. And they also asked the patients involved in the study to record their daily, weekly, and monthly itch score. What they found over a period of 24 weeks, the interleukin reduction was greater in the intervention group in comparison to the placebo group, and the reduction was associated with the reduction in the itch score. So the data provide a key insight that potential mechanism by which the linerixibat may mediate reduction in the pruritis via the reduction interleukin 31 level.
2 minutes, Doctor.
Oh, sure. I'm gonna skip this. Oh. Another important study on the seladelpar, and actually it's not a new study, but it's an extension study, a short study that were looking at the follow-up of people who were starting the seladelpar as a second-line therapy for PBC. In the follow-up period, after the initial 12-month period, they followed people the study is still ongoing, but they reported the data collected at 30 months. They found significant improvement again, and the improvement is sustained and progressive. And again, this is an extension study of the long-term treatment of elafibranor, similar study to the first one, but with a different medication. And but it did not look at the pruritis only, but it looks at the outcome overall in PBC. But of course, they commented on the improvement and the persistent effect of medication on the pruritis itself. Again, small studies presented at small abstracts presented at the ASLD on exploring the role of IBAT inhibitors like volixibat in regulation of interleukin-31, and it's a preliminary results only. And another small study that included only 12 patients to see if there is an effect between a specific opioid agent in response to opioid antagonists in cholestatic patients with pruritis, but it needs a lot of study to confirm the data. So the take-home message from this presentation, pruritis is measurable, modifiable, and clinically meaningful endpoint in treating PBC, and it's soon to be no longer an undertreated symptoms. Newer drugs are reshaping the care by offering earlier, more effective, and tolerable option. Thank you.